Welcome to SIMA Sessions, a podcast from SIMA Surgical Intelligence. I'm Antaki, an ophthalmologist specializing in retina surgery. In this series, I sit down with surgeons from around the globe to talk about how surgical expertise is really built. We talk about the parts of surgery that are hardest to teach formally, how surgical judgment develops, what experienced surgeons see when they watch a fellow operate, what habits matter more than people realize, and what lessons only become clear after years in the operating room. For this episode, I'm joined by Dr. Danny Mammo, a vitreoretinal surgeon at the Cleveland Clinic SIMA Institute, who will soon be moving to the Pacific Northwest to join Washington Retina in the Seattle area. I had the chance to learn from Danny during fellowship at Cole. He is an exceptional clinician, surgeon, teacher, and his practice covers the full breadth of medical and surgical retina, including complex uveitis. He often manages some of the most challenging cases that came to our service. Danny completed medical school at Oakland University William Beaumont School of Medicine, followed by ophthalmology residency at the University of Minnesota. He then went to the Cleveland Clinic for vitreoretinal surgery and uveitis fellowship before joining faculty in 2022. He has received numerous teaching awards, including the Heat Fellowship Award, Fellow Teacher of the Year Award, and the SIMA Institute Retina Faculty Clinical Teacher of the Year Award. So Danny, thank you so much for being here. I'm very happy to host you in Montreal during this ASRS meeting.
Thank you, Faris. It's great to be here. Great to be in Montreal, in your hometown. And I look forward to our discussion.
Awesome.
I will say no one probably gets to introduce you on these podcasts, but it was a pleasure to teach you. You're an exceptional fellow, and it was a pleasure to have you in the OR always.
Thank you. So I want to start with the idea behind this podcast, deliberate surgical learning. If you had to break down your evolution as a surgeon, maybe from being a even medical student to resident, then fellow, then a young attending, what would those phases be? How would you describe them? What are you doing at those different phases of your training?
Sure. So if we're going back to medical school, I guess just even when you asked that, I kind of thought about how far I've come. I remember when I was first interested in potentially being retina as a medical student, I was shadowing and working with some wonderful residents who were very patient with me. And I said, why don't I take a stab at looking at the back of the eye with an indirect? And I put this headset on my head. I took a lens. I forget if it was a 20 or 28 diopter from the resident. And I was standing maybe 6 feet away from the patient, shining up this light and lens, trying to look in the back of the eye. And, obviously we know that you have to be closer to the patient than that. And actually what's funny is the program director of that program as a medical student walked in the room then, and he must have looked and thought, what is this kind of guy doing right now? So I basically started from very little limited knowledge. I didn't know I wanted ophthalmology. I did not know I wanted retina until a little late in medical school. So I did not spend a lot of time learning it until I realized, wow, there's this piece of small tissue in the back of the eye called the retina, where you could see and diagnose many different systemic diseases, which probably is why I ended up being interested in uveitis as well. So after I realized that I loved retina, my first job was trying to figure out how to see the retina. But I think from the beginning, my most common thread was always being hungry and wanting to learn. So my first foray in a retina clinic, there was a retina surgeon who was about to do an after-hours case. And I was simply going there just to meet one of the other doctors, Dr. Yoshio Onakawa. But then Dr. Ash Abbey walked in, and he was about to do a retina case after hours with Dr. Tony Capone. And they kindly asked if I wanted to join, and I jumped at the opportunity. I didn't care if it was after hours. In residency, I didn't care if surgical mentors were operating on the weekends. I was always hungry, and I always tried to consume retina. And that allowed me, I think, to have the natural progression that I think everyone has, where you obviously, struggle at the beginning, then you slowly improve your techniques. But I think even then, when I felt that I was quote unquote good enough, I was still always hungry, always trying to learn more. And I still am to this day. I love going to surgical conferences. I love picking up tips and tricks along the way.
That's a great segue onto my next question is, you mentioned your continuous hunger to to learn, other than this inner motivation that you had at the different stages of, becoming a surgeon? What has been most important? So at your stage now, is it more mentorship, or is it more just doing more cases that helps you the most? What do you think it is?
That's a great question. At this stage, doing so many cases, they almost become routine. Critical analysis of your data, I think, is the most important. It's very easy to get caught up in thinking that, oh, this is just a routine ERM, this case is going to be fine. This is just a routine retinal detachment, this case will be fine. As you know, I am a big believer in using pre-op imaging to help prepare for my cases to try to lower the odds of surprises. What we're doing in surgery, we cannot eliminate all risk, but I'm a strong believer in lowering the odds. I love sports, right? So in sports, you're always trying to gain any small percent of advantage over your opponent. And these days, we have much more capable analytics and film study than athletes of the past. Well, same with surgery. We have amazing multimodal imaging that can maybe show you where neovascularization is, can show you whether the hyaloid is up or down, can show you whether there's choroidal thickening that may affect your, trocar placement. One case where you decide to enter the retina with your trocars straight in rather than beveling can prevent you from having that one rare surprise of your trocar being buried under the choroid and, delaying your case while you're trying to fix that mess. So I think increasing your odds of success by analyzing your cases and data, that should never be stopped, but it's so easy to stop and just get in the routine.
And how did you, get into being so meticulous about your pre-op evaluation? So looking at all those factors and, training with you, I know in your preoperative notes, you always have a plan for what you're going to do in the surgery. So when did that click? Is it you think this is innate? This is something this is your personality, or you saw someone do it and then you emulated that?
That's such a good question. Nature versus nurture, right? I mean, like all these hard questions, the answer is a little bit of everything. But a lot of it came from seeing how successful people perform their skill. And I don't just say retina. As I said, I love sports. So a lot of my OCD-ness about preparation actually came from where I went to college. So I went to Duke. I'm a huge Duke basketball fan. And Coach K, who's now retired, was the coach when I was there. And he was notorious for preparation, motivation, never taking any game for granted. And I really related to that concept and that degree of preparation. And I translated that into how I wanted to do surgery. And then in terms of the meticulousness, I trained somewhere in residency where I was able to be mentored by people from a wonderful academic private practice in the Minneapolis area, where they were doing many, many cases a day well and efficiently. And I saw that to do that well, you really couldn't enter cases not knowing what you were going to do, or you couldn't enter a case and have a surprise and then kind of sit there and ponder and wonder how you're going to manage the surprise. You had to be very prepared for the case, but not only that, you needed a lot of reps to be prepared for any setback or complication that might happen during the case. Well, no one, until you get to a certain stage, many years in your career, depending on how busy your practice is, will get enough reps right away. So I wanted to fast track my learning. Any surgery I could participate in, even if it's just an observer, I would do it. Any surgical conference, I would do it. When I was training, COVID happened. COVID opened up this world to Zoom webinars, people publishing their grand rounds, people publishing their surgical conferences. I would consume all of them. And the more you do it, the less you learn. Right? I mean, how many times are you going to watch someone do a non-clearing vitreous hemorrhage and know how to do it? But the more you do it, the more you pick up on maybe some unique or rare things that you might not have picked up before. So now I might watch a conference or listen to a podcast. And whereas when I was a medical student or resident, everything was new to me. I was writing notes. Everything was new. Now I might listen and be bored for 25 minutes, but then in the 26th minute, there's a beautiful pearl that I can now apply to my practice that I never had before.
So you mentioned something, an interesting word. Maybe I mentioned it, but meticulous. The last episode I had Sunil Srivastava, who you know really well, and then we were talking about surgical efficiency. And he said that some people describe themselves as meticulous surgeons, and that's typically when they're slow. And then some people will say they are efficient surgeons, and that's typically when, they get things done quickly. But you seem to be able to be meticulous and efficient at the same time. And I think they go hand in hand. Can you comment on how being meticulous helps you being efficient?
Yeah, I think that's a great point. I definitely think they go hand in hand. You can be fast at surgery and not be meticulous. But I think fast and efficient are two different things. I've had fellows come with me, and they know that I try to be an efficient surgeon, and they will try to move very quickly. And I will have to pause them and say, look, I don't want you to move fast when you're peeling. I don't want you to move fast when you're shaving, but I do want you to move fast when you're getting the patient in the room, prepping them, getting everything ready, to give yourself more time during the surgery to do what you need to do. And then I want your movements to be efficient, not fast. So I try to explain why we do certain things. So I think being meticulous allows you to be efficient. And it's not just meticulous, as I mentioned, during the surgery. It's meticulous in pre-op, when you're seeing the patient in your clinic. And something I like to tell my fellows is I like to think, but I don't like to think twice or three times about the same thing. So we're seeing, obviously, so many patients, whatever institution or practice you work at, there's always a pressure to see more and do more. So to do that successfully, when I'm thinking about a patient, whether it's a surgical plan or a differential diagnosis, or what I'm going to do if the treatment I do doesn't work, I write down what I thought. I write down what I thought in a very efficient way that I can understand. So when I do pull up that chart before surgery, I know, okay, I already thought about these things. I'm going to use a 6mm cannula for this, things like that. I already know that this plan is there. I've already thought once. I don't want to have to think multiple times. And that's what allows me to get through my days very efficiently as well.
So you like to document, so I'm going to do this plan, and if it fails, I'm going to go to plan B. And let's say if it fails, plan C. And this, you'll as you said, you'll think about it once. And then next time you see that patient, you can do that. Do you recommend trainees try to, put themselves out there, take the risk of writing something like that in a chart?
Absolutely.
Mm-hmm.
The best fellows I see are hungry. They're always thinking about the next step. They're always trying to figure out, why did the attending write this down? What surprises might I find during surgery? How might I want to fix this retinal detachment? And it's okay to be wrong. I mean, when I was a fellow, I remember writing down in the chart, possibly consider this. And I left the room, and later that day, the attending said, never write that. Tell me what you're going to do. I'm coming after you. I will delete it. I will fix it. I want you to commit to something. And I think that practice of committing when you're a trainee, if you're at a very supportive institution, is very important to practice your mind and your muscles on committing to plans. I think that's very valuable, rather than just continuing to go through your training, possibly considering this plan, because then when you get out in the real world, you are the person that has to actually make a commitment, and now you're practicing it on patients before you were practicing as a trainee.
So being definitive, and hopefully you're being definitive based on real knowledge, based on you really thought about the case, and then you suggest what you really want to do for that patient.
Yeah.
In a definitive manner. Mm-hmm.
Yeah, and you bring up a good point. It's not easy what we do.
Mm-hmm.
There's a lot of preparation and study that goes into having the knowledge to be definitive. It's always amazing to me. Kobe Bryant, rest in peace. He was training and coming to practice court before his whole teammates. He was leaving after his teammates. We hear about some of the top tennis players in the world firing their coaches and hiring a new coach when they're in their 30s. What more can a coach teach you? But these people at the top of their games are continually having coaches analyzing their games. What's different about what we do? So I think it's very valuable to always be learning.
So I want to shift gears to talk specifically about surgical learning. So how trainees learn how to do surgery. And a lot of surgical expertise that we build over time is hard to describe, because it's really sometimes small details, small things we do that make our surgery better or worse. And those differences are amplified when you're early in your training, because sometimes you're just afraid to do the next move. You don't know what alternatives you can do. When you watch a trainee operate for the first time, they may not know all the steps that they need to do. But occasionally you get a feeling of how good they might become or how good they might be. What are the things you're looking at when of how they behave, how they move in an eye, or even how they just how they talk to a patient?
I think at the beginning, you're exactly right. No one comes in the door being amazing at retina surgery. Nobody. It's such a unique thing, especially compared to doing 3-4 years of cataract surgery from residency. It's a totally different feeling and thought process. So one of the biggest things I look at is actually, does the fellow care? Does the fellow care about the patient in front of them? Does the fellow care about doing a good job? Which is very different than does a fellow care about impressing the intending. I don't want to be impressed. I want to see that the fellow cares. Because if the fellow cares, I think everything else will naturally follow. If the fellow wants to be a great surgeon, they will be voracious in appetite and hunger in not only trying to learn as much as they can from me, but also from all the other surgeons out there. As I said, a lot of learning is democratized now. It's not just only at your institution. You can also learn from watching and listening to a lot of things. I mean, we're here at ASRS right now. Yesterday, there was many surgeries presented with a panel where people could learn from other people. So if the fellow cares, I think that's the most important thing to me. I'm also looking at their hands. Not do they know what to do in the eye? They won't in the first few weeks or even months, but are their hands steady? It's very important to have steady hands. Sometimes fellows might not, and if we can identify that early, there are ways to help with that. There are always some physical reasons that a fellow might have a tremor, but many of the times it is mental. And if I notice that a fellow has shaky hands, it is something that we can proactively address and fix some of the mental roadblocks that might be there that contribute to that. Or if there are some physical limitations, there are also ways to address those as well. Because if the hands continue to be shaky, that can limit confidence and limit learning. So I want to know that they have good hands. I want to know that they care about the patient. And then after the case, I want to see that they can learn either from what they couldn't do, or if they made a mistake, from mistakes they made. I will spend a lot of time with fellows at the beginning, teaching them why I do things, teaching them why they do something incorrect. However, if in the weeks that follow, they continue to make the same mistakes over and over and over, this is very discouraging for me as a teacher, because it's not showing me that they care. Because if they cared, they would have went home and analyzed, why do I keep making this mistake? How can I fix it? It's not, I can't do everything. I can point out the flaws, but I want someone that has the self-motivation and hunger to also want self-improvement themselves.
It seems like becoming a surgeon is something very personal. So you can train at the best institutions in the world, but if you don't have that inner motivation to continuously improve, you will not become a great surgeon. Whereas sometimes you'll watch and, if you go and meet people around the globe, they have all odds stacked against them to become great surgeons because of war, circumstances, lack of resources, but they have this inner drive, inner motivation to continue to iterate and improve and learn, and they become fantastic surgeons, and also they get to do tons of volume. So what are your thoughts on learning from our international colleagues?
Yes, I think that's excellent. ASRS, Vit Buckle Society, they have really allowed us to see what international surgeons are doing. And this is kind of a bit of that analogy I gave earlier about maybe, being bored for 25 minutes. In the 26th minute, I learn a new pearl. Oftentimes these days, a lot of this comes from an international surgeon. The way they might fix a macular hole. Asian countries who deal with very highly myopic macular holes. What are techniques they do that we might not see as much here? These things have actually affected how I practice. One of the most beautiful things in our field is how many different ways there are to do something. So going back to how a fellow processes things, we train at Cole where there are, I don't know how many now, but many different surgical retina attendings. Of course, we all do things differently. Of course, I will tell a fellow, I want you to do it this way. And they will say, oh, but the other surgeon wants to do it this way. Well, there are some fellows who are very dogmatic. The other surgeon said this. How can we do it another way? Whereas the good fellows understand that there are multiple ways to skin a cat. Sorry for the cat lovers out there. And, there are some things that if it gets to a similar end game, if you understand why we're doing certain things, you'll understand that there are different ways of fixing this or approaching this problem and approaching the retina, and you'll actually learn to understand the value of learning those multiple ways. So a great example. There are some surgeons that don't like to peel over detached retina. There are some surgeons that like to peel over detached retina without using a third hand like PFO. And there are some surgeons that like to stain and then put PFO and then peel over detached retina under PFO. I was exposed to all of these maneuvers as a fellow. And it was amazing because when I was out in practice, there have been many cases, PVR cases, where I wanted to peel and one method wasn't successful for me. So I transitioned to another method, which ended up being successful. And I think seeing these multiple ways and trying to incorporate them and constantly taking notes, whether you take notes by hand or in your head, and wanting to incorporate these things in your practice is of the utmost importance to be a successful retina surgeon.
Great. I want to comment on a blog post I saw recently by Cataract Coach. He had posted this a couple of years ago. So Uday Devgan, who's a fantastic cataract teacher for all of our residents watching, I highly recommend you check out his content. You probably have seen it before. He describes three kinds of surgeons. The dropout, who is never able to surpass the frustration of learning surgery and then eventually stops doing surgery because it's just way too stressful. And then you'll have I'm going to call them the average, surgeon who did well but plateaus very early and then doesn't learn new technique. And then you'll have the deliberate, exceptional surgeons who progress at different rates, but they continue to improve, they continue to iterate, and then they surpass others. They become really good surgeons. And one thing I've been interested in is, thinking of how we can help young surgeons be on that path, become great surgeons. You've touched on a variety of things. What are practical ways that, you were doing other than just consuming retina, but just when preparing for a case or being in the OR, any tips you would have for our young surgeons?
I think going back to what I was just saying about how you can skin a cat in different ways. If I say exactly what I did, I also strongly believe that how I did it might not be right for somebody else. For example, I never touched the IC once. I didn't even go to the wet lab that much. I went a little bit to practice some suturing, especially 10-0 nylons, especially when one of my attendings in fellowship yelled at me during a case for not being able to suture the cornea very well. But I never went to the IC very much. I learned by kind of going down rabbit holes. I would realize I was struggling with X. I would go online and try to find videos, which would take me down more rabbit holes about reading. I would talk to mentors. I was blessed with many great mentors, all the way from medical school to residency to fellowship, retina mentors. And I would ask them, how do you challenge this? I'm blessed to have many friends across the country in retina that I trust very much. I would text them. I would call them. I would learn from them. But that's not necessarily the prescription for everybody. I think some people do great with the IC. I've had fellows that struggled, went to the IC for weeks at a time, improved greatly. But what's the common denominator of all this? Hunger, desire to improve. So there's not one prescription that can make a fellow average to above average. But I would say is if you do what the ACGME says is competent. I don't even know what the numbers are these days. Graduate with this much, do this. Your residents graduate with this, and then just apply to retina. You will be average. To be above average, you need to do more than average. Otherwise, there's no way. We just talked how it's not really just an innate ability. This is something that everyone can learn. I truly believe that. If you're a competent cataract surgeon, you can learn to be a very good retina surgeon. You've already proven you have good hands with cataract surgery. So I think if you're hungry, you find a way. You gave great analysis of people that might be in less privileged countries. Of course, there are circumstances that even if you are hungry, you still can't maybe make it out. You still need a little bit of luck. But here, in America, if you've matched in fellowship, if you're hungry, you will find a way. You'll be resourceful. The amount of resources there even now are so much more than even I had. And I'm a recent graduate. So the amount of resources is growing each and every day. Now we have the COBRA webinars, for those of you that don't know, a surgical conference that happens with Cole Eye Institute and Byers Eye Institute. This was just starting when I was a fellow. And this happens quite frequently. All the videos are archived online. You can hear from how wonderful Cleveland Clinic and Stanford retina surgeons approach cases. There are so many ways now that if you're hungry, you will find a way. I truly believe that.
Can you talk about parallels between how a surgeon is, how they behave, how they have this hunger, and perhaps how you think it can have parallels outside of medicine and maybe from your own experience. So um, you constantly want to improve, and in surgery, we see that you're meticulous, you break things down, and that may also be a personality trait. So can you talk about maybe how in your personal life you do some of those things? And I want to ask about that because we work with trainees from every kind of people, and people are different. So sometimes we expect them to have that inner drive to improve, but in reality, their personality may be completely different, and they're maybe just like surfers. They just show up and things happen, and things have happened and worked for a long time. What are your thoughts on that?
That's a good thought. I will say there's a few excellent retina surgeons that are surfers. So I don't think surfing precludes someone from being a great retina specialist. But to that point, I wouldn't say that I am so meticulous or OCD in all aspects of my life, which is interesting. Like my wife probably thought I would wish I was more meticulous with maybe cleaning up around the house than I am, like I would be during surgery. So, but I will say that I played sports from a young age, and I loved watching sports as well. And I will say the obsession I had with gaining an edge, scouting, maximizing whatever the team had and reaching full potential, that is kind of something I always was attracted to. And I think that part of my personal life has translated to my, medical and surgical retina career. But in terms of whether you have to be that type of person in every aspect of your life to be a retina surgeon, I actually totally disagree. In fact, I think I'd probably go crazy if I was like that in all aspects of my life. But I think surgery kind of maybe when a athlete says that, when they get on the field, their personal, problems go away, maybe try to treat the surgical arena like that. The surgical arena is a space for you to enjoy your craft, make someone see better, preserve someone's vision, bring their vision back. It's a very privileged space that we're allowed to be in. And I think it's frankly crazy and ridiculous not to approach it with the rigor and meticulousness that athletes do. I mean, athletes are just playing a sport. We are actually operating on people's eyes. We're contributing to the economy when we operate on younger people. Sometimes our surgeries are the difference between them staying in the workforce and not staying in the workforce. So I think it's important to take that responsibility very seriously. And that kind of goes back to the beginning when I said I want to know that a fellow cares, because, if you care, I think a lot of the other things naturally will follow.
Just to clear one thing up, surfing, I meant cruising, showing up and not being deliberate. Nothing against surfing, and I'll give a shout out to my colleagues in Brazil who are fantastic surgeons and typically great surfers. One of the things we dread the most is complications, and every surgeon will have complications if they operate enough and if they have the courage to take on complex cases. In an interview you did a couple of years ago, you cited the French surgeon René Leriche, who said, "Every surgeon carries within himself a small cemetery where from time to time he goes to pray for an explanation of his failures." Can you comment on how you deal with complications in practice?
Yeah. Complications I think are not easy. I operate usually, unless I'm doing after hours cases, on Fridays. So my wife knows if we're going to have a good weekend or not based on how the Friday went. And I don't think that's a bad thing. I think that it's a bad thing if you become numb to your complications. So I would say a few things. Number one, first off, you have to know if you have complications. You have to track them. I mean, without naming names, I've been shocked. I've heard retina surgeons say, "Oh, I don't get PVR. Oh, my macular hole closure rate is 100%. Okay, well, as someone who operates a lot, I don't, either people are not tracking their outcomes well, if you're saying something like that, or you're not operating enough, because everybody gets complications. Everybody will get a macular hole that doesn't close. Everybody will get PVR. So I think it's important to track them. Now, not shameless plug here for an amazing artificial intelligence-based surgical log that Faris has developed with some of my guidance called SIMA. I think it's incredible. I still log all my cases. And before SIMA, I have an Excel sheet that I have from back to my fellowship that I still look to this day. I take notes after all my cases. The notes have become shorter over the years as cases have become more routine for me. But for non-routine cases, I still take notes because we forget. I will Control F, go back, choroidal hemorrhage, inadvertent touch of the macula. Code words that I might use to document in my notes, I will go back and look and see how often did those happen? Why did they happen? What did I write about that time? And I might write, like, I was in a rush, too focused on getting to the next case. And I will try to remind myself of why I think a complication might happen. Didn't take over for the fellow soon enough, didn't guide the fellow well enough, wanted the fellow to be too aggressive. Things that will always help me remind me in the future why I thought a complication might happen. I think it's very important. So that's analyzing why complications occur. So I think it's very important to log cases, and not just log cases, but log outcomes. So it's kind of annoying for me until SIMA because of Excel sheet. But with SIMA, you can go back and say, show me all my vit buckles. And you can go to your EMR and you can then see which one's attached, not, and you can kind of quickly calculate what is your single surgery success rate. Same thing for macular holes. I think it's very important to grade yourself to a benchmark. I heard of a practice that I admire very much, who was tracking all of the surgeon outcomes for single surgery success rate. Now, it was not tied to any financial metrics. It was simply just the group wanted to be excellent. And I admire that culture and that feedback. And if any person was below a benchmark of single surgery anatomic success, they just talk to them. Why? Why do you think everyone else is here and you're there? What are some changes to your technique or preparation that might be able to improve things? I think that type of culture is amazing. I think that type of culture is very rare. And not just our field, but most fields of medicine. We've trained so much. We don't really get to start practicing on our own, earning our incomes until our 30s. We have egos. It's very hard to want to analyze your outcomes and figure out why you might be different than other people or why you might have failed in certain cases. So that's number one. Number two, when you have an outcome, I think it's important to have support. So, emotionally, it's very important to rely on friends and mentors who are in the field that have had complications and just get support from them. Have them remind you that, you are a good surgeon. You really meant well for the patient. And then lastly, how you talk to patients about that. In my experience, being honest, showing patients you care about them, patients usually understand. And they understand the high stakes of what we're doing if you've counseled them appropriately. And they just want to know that you're there for them and you care.
This brings me to the next section of this podcast, one of the recurring segments called the hidden curriculum. I will name a few sentences, and then I'll ask you to complete the sentence with what you think. Nobody tells you that surgery is really about...
Nobody tells you that surgery is really about mental preparation, okay? Getting from case to case, especially if a complication happens earlier in the day. Your turnover is fast, hopefully. You have to regroup pretty quickly. So I think being mentally prepared, being able to block out the outside noise of whatever's going on in your life or that day is very important.
The best surgeons are not the ones who
move the fastest. Okay, I think move efficiently and move the fastest are two very different things.
Hardest thing to teach is
anticipation. I think anticipation is very important to being efficient and very important to consistently doing things in a similar fashion. And I think anticipation involves a lot of critical thinking, and a lot of the brain always has to be running. Not just running through the motions, but anticipating what's next, talking to the scrub tech.
A trainee becomes dangerous when
they don't think they can improve anymore.
Mistake I see young surgeons make is
try to move fast from the very beginning.
Great. Now we're going to play a game of split decision. I'll give you two options. You have to pick one first, even if the real answer is it depends, and then you can explain the nuance. Is it better to have exceptional hands or exceptional bedside manner?
Oh, this is tough. I think that you can be a great surgeon having, good hands, but I think it's important for the longevity of, your practice and how you make your patients feel to have exceptional bedside manner.
This is the same answer that Sunil gave at the last one.
I changed my answer.
It's true. He said what was interesting is that the delta difference between, having really good bedside manner or bad bedside manner is more important than the difference of having great hands or just good hands, because over time you can find ways to do the things you want to achieve intraoperatively. And you seem to share that,
Exactly.
that feeling.
Yeah, I totally agree with that.
Should a surgeon operate on a friend or family, or should they refer them to a colleague?
Well, I think friend or family is a little bit different. There are a lot of cultural aspects to this as well. Okay. We're in Canada now, but I would say in America, from an ethics standpoint and trying to, check the boxes and follow whatever the AMA Code of Ethics says you should do, you should not. But I don't think it's as black and white. We are a country of immigrants, many different cultures, and I think it's very cultural. I think in some cultures it can be accepted, in some family dynamics it can be accepted to operate on a friend or family member, and I personally would have no issue with it in certain circumstances.
Specifically, I guess if you're on call, you're the only surgeon available, you have to do what you have to do.
That would be one scenario, but I think that there are other scenarios in different cultures where it might even be considered rude not to operate on someone. And there's a certain trust, for example, like litigation and malpractice issues are not as common in other places as, America or Western cultures. So it's a bit of a different mindset for this discussion. I think it's a little more nuanced, but, for the vast majority of cases, especially in America, the answer usually will be no.
And why do you think those rules exist? Is it because we think that as a surgeon, you may be affected and not be able to perform your task as well as operating on someone you don't know?
There might be a bias related to not being able to assess the case in totality. If it's not just a surgical case, but if there's a, uveitis, maybe there's some questions I wouldn't feel comfortable asking a family member or a friend that I would ask every other patient that walks in my door. So you have to also know in yourself whether you're treating that friend or family just like you would other patients. And I think in some cultures you can make that relationship happen, but in others it might be too difficult.
It's an interesting concept, question I've thought about recently. And I think as a trainee, you don't really think about, operating on friends and family. But when you move to a city or you come back to a city where you know a lot of people can become friends and extended family, and then inevitably you're going to have to think about those things. So, if you're watching this and you're just starting a job and it's a small town, you may want to think about how you want to deal with those things.
Yeah, good thoughts.
As a teacher, is it more important to be honest with your feedback, even if it hurts, or to sugarcoat things not to hurt anyone's feelings? And I want to ask this question because it is really hard to give people feedback. I think some of the best feedback I got was really brutally honest feedback, because I had a feeling that person who's giving me that feedback, that attending, is putting themselves in a difficult position. They're being uncomfortable and taking the time to tell me something that I need to hear. Whereas sometimes you'll get feedback and it's like sugar-coated, or they'll tell you, oh, it's so easy. They tell you, oh, everything's going great, but is it really? So what's your take on like giving feedback?
Yeah, I'm a strong believer in the former. I think you have to be brutally honest. That's becoming more and more controversial these days. People want the compliment sandwich. People might not even want the compliment sandwich. They just want the compliment, deluxe burger without any brutal feedback. And that has a lot also to do with culturally where we're at these days. It's also easier for faculty to just give them a sugarcoating of feedback, because then they're not the bad guy or bad girl. I think you have to be brutally honest. I want people to improve, and people need to know where their shortcomings are, but people also need to know that you care. So I make sure they know that they care. I make sure that they know, hey, the second years are literally doing all my cases. Like, if you listen to me, you'll get there. You will do all the cases. You're going to be there one day by yourself without a fellow. You need to know these things. So I think you have to be brutally honest. Also, we have limited time. We are busy in our clinics. We're busy in our surgeries. I need to be directly honest with fellows so they can try to get better as fast as they can. And How honest, how brutal, I think that depends on the fellow. That's my job as a teacher, to assess how can they get this feedback. But if I see something is wrong being done, I will always say it in some way. And this has very rarely happened. But if I'm not saying it, that means I've become convinced over weeks and months that the fellow doesn't care, that the fellow's going to repeat to make mistakes, and they don't care enough to take the brutal feedback and internalize it and not make these mistakes again.
You're right. I mean, it has, from everything you see online, you hear in medical schools and residency programs, there has been perhaps a shift in, feedback, education. Maybe COVID played a role, but I think people are way more laid back. They're cruising, they're surfing. And it is much easier to give positive feedback or say good job. Or the worst is not to say anything. And as you said, if someone who's a great teacher is not telling you anything, it means something's off. And all my respects to all of the teachers I've had who were honest with me and gave me specific things to improve and get better, because I know how difficult it can be for them to put themselves in this position to give that kind of feedback. So I personally always appreciate it, but I can imagine that not all trainees will accept feedback the same way.
Yeah, it is becoming, I think, more challenging, and it's our job, I think, to figure out how to most appropriately relay feedback to different types of fellows.
I want to move on to another segment, which is the skill I'd steal. So I'd like you to name a surgeon you've operated with, you've learned from, you've watched, and then one skill you'd steal from them, whether it is an interpersonal skill or something specific in the operating room, perhaps not a specific technique, but an approach.
That's a great question. So as you've heard me talk today, I am a strong believer in rolling over things I've learned. I mean, it's remarkable. Obviously, all the credit goes to Cole Institute for my wonderful fellowship and my amazing surgical mentors that taught me what I do. Especially my, former program director, Dr. Sunil Srivastava. But I've incorporated things all the way from that first time I mentioned I shadowed as a medical student at Beaumont to my experience in Minnesota. And I will never forget, I was, with Dr. John Davies in Minneapolis, Minnesota. I was a resident, did not know much about the retina, knew very little about retina surgery. And I was shadowing him at the observer side scope of a retinal detachment case. And he goes in the eye, and I'm still trying to process everything I just saw in the previous few minutes. And maybe within a few seconds, he asked me, how do you fix this? How would you drain it? And I'm just trying to get my bearings straight. And he's trying to figure out, he's trying to get me to answer, are you going to drain from the break? Are you going to make a retinotomy? Are you going to use PFO? How are you going to drain this? And that was a very enlightening moment for me. I was very uncomfortable. I didn't know how to respond because one, I didn't have the knowledge base. So I went back and, fixed that week and the week after. But then also, I wasn't able to process what was going on so quickly to make an anticipatory decision. And that experience kind of shaped how I approach surgery. I'm always now thinking anticipation. What's next? What can I do next? So that skill has kind of shaped where I'm at. And even now, when you're doing such routine things, it becomes easy to try to not anticipate. So it takes that mental focus and drive to continue try to wonder, okay, what might go wrong? What might not go wrong? Is something off today? Do I have a new scrub tech? What might a new scrub tech bring new variables into this day that I'm normally not used to? Do I have a new fellow? Do I not have an assistant? These are all things you need to anticipate. How might these things affect you? Surgery is not just done with what I'm doing. I also rely on other people. So how might other things affect what's going on?
So being perceptive, anticipating, being, observant, look at things, and be ready for what could go wrong. Mm-hmm. Talking about external factors, we'll move on to the last recurring segment as we wrap up. Really a couple of questions about external factors that can affect us. Do you have coffee before surgery?
So I did not start drinking coffee until COVID in residency. Once I figured out how wonderful a feeling it gives you and how much energy it gives you. I do not drink coffee before surgery on my Fridays. However, I'm an evolving surgeon, and I've started to become, unfortunately, more resistant to the effects of caffeine. And occasionally I have coffee and it really hasn't caused any issues. But if you are a new coffee drinker, I do think that avoiding it the morning of surgery, if you're going to do some peeling, is a good idea.
That's a feeling I shared. I mean, when I was a resident, I stopped drinking coffee and then I started drinking tea, perhaps for a little bit of caffeine, not to have a headache. And then at some point I was operating with Sumit Sharma, and he's like, yeah, I just have like 3 cups of coffee during the day. Nothing happens. And then I started like taking a little bit of coffee, and actually occasionally I felt it made me a little bit better because I was like a little bit more on edge and like efficient perhaps, but you have to kind of, it's very personal.
I think it's very personal, very mental. You know, for me now, it's not, I don't drink coffee because I think it's going to affect me. It's more that on my OR days, my first cup of coffee was more of a reward after surgery ends. And now I just kind of have kept that routine. I'm like, oh, it's a nice reward to have that cup of coffee after my surgery day ends.
Is that something you learned from John Sears? Because he always talks about that. He's like, oh, doesn't it taste so much better now that everything's done?
See, I'm always learning from John Sears when I thought I had everything to learn, but no, I hadn't heard him say that yet.
Now, my next question, I think I know the answer. We've talked about this at length, but I just want to make it clear to everyone who's watching. Should you record your surgical cases?
Yes, I think it's a no-brainer to record your surgical cases. First, you never know when you're going to need them. Second, you never know when you might have an outcome you did not expect. You walk in the room on post-op month 1, you're so excited to see that gas bubble go above the macula and see that retina attached. You walk in and, my gosh, the macula is detached. I thought this case went perfect. What went wrong? You can go back and watch it. I think it's very important to record. It's so easy these days with the microscopes, and I think it's a no-brainer to record the surgeries.
How about recording time? So oftentimes in our surgical reports, you know, in our electronic medical record, oftentimes is auto-populated, so you can get a sense of, you know, how fast the case took. Is that, not that you should chase that metric specifically, but is it useful to get a sense of how long each of your surgeries take?
Absolutely. Some people would even call this controversial, and I might be controversial in saying I think it's a no-brainer. I think if you are not watching your times, you are not taking the approach of analyzing how can I improve. You know, if you're doing, and I don't know what the exact times are that people should be aiming for. If you're off by, you know, 10 to 20 minutes, fine from the average retina surgeon. But, you know, if you're taking 3 hours to do a vitrectomy, scleral buckle combined for routine non-PVR case, and many other people are doing that case in much less, that gives an opportunity for you to learn what are some other efficient ways, what are some maneuvers I'm doing that might not be necessary. You know, what are some times of the case where I might be thinking what to do that I can make faster with some more pre-op planning. Many different ways to become more efficient. So I do think tracking time is important. And like everything we've talked about today, there's not, you know, one correct answer that's going to make you a good surgeon. So if you're a first-year fellow or even second-year fellow and you're tracking and you're seeing you're doing your peels longer than you should, it's not something to chase, but it's something to track. Like it should be getting faster throughout your 2 years. You know, if you're still doing a peel the same amount of time 18 months in as 6 months in, you know, that trend should be getting better.
So again, it's more about, you know, getting time is just another data point of perhaps proficiency, you know, and what is proficiency? Proficiency, I guess, is being able to do the things you want to do in an economical way. So little maneuvers, and maybe that's what's a good surgeon. What do you think?
Yeah, I agree with that. So obviously you want to obtain the anatomical outcome that we aim for in surgery. You want to do it in a way that's safe. The more time we talked earlier about sports, odds, increasing your odds for success. The longer you're in an eye, you're increasing your odds of a complication. If you don't need to be in the eye for longer than you have to be, get out. You know, IOP issues can worsen glaucoma, worsen RNFL issues. Unnecessary, crazy, large amounts of peeling can damage the RNFL more. Longer times to retinal detachments may increase the risk of PVR. May increase the risk if you're operating the fellows of a rare fellow complication. Longer cases, more manipulation may increase the risk of the infusion moving its area and causing a complication you never envisioned before. So I think that watching your time is important. Also, even in hospital institutions, leaders are becoming more mindful of cost. They're becoming more mindful of efficiencies. If you are operating longer than you need to, you are incurring more costs to the system and not allowing your time to do other cases. We're also now supposed to be stewards of our ORs. The longer you're in an OR necessarily, the less time there is to do that add-on retinal detachment. So I think there's so many things that go into being a good and thoughtful surgeon that are not just part of, operating on the patient.
Time, rhythm, efficiency sometimes can be helped by music. What's your take on music? And I want to mention this thing. So when I was operating with Danny, we had our old operating rooms at Cole, then moved to new operating rooms. And in the old operating rooms, he would always play the same playlist. And the first song is always American Pie by Don McLean. And I love this song. So can you comment just briefly on, is music good in the operating room? Is it the same playlist? Do you like lyrics, no lyrics? What's your take?
Music is great in the operating room. I'm not picky. I've recently been loving instrumentals of popular pop songs. DJ Skisis, Sarwar Zahid has an amazing podcast on this, playlist on this. And but I also love just, lyrics with great music. Honestly, what I love about it is, I mentioned earlier, operating is not just about what's in front of you. Operating is about keeping your staff engaged, keeping your staff happy, making sure that the people in the room are not just bored out of their mind while you're peeling a PVR membrane. So I think music keeps the whole OR a little bit engaged, keeps the mood more elevated, keeps people happier to move things along. All these things I think are so vital to a successful surgery day. And then, I like music, so, I don't mind it.
On that positive note, we're going to end the podcast. Thank you so much, Danny, for coming to Montreal and recording this session in our studio. It's been a great pleasure to learn from you in the last 2 years and become friends, and I hope to continue to learn from you. And I hope everyone watching found this interesting. We're going to have additional sessions being recorded, so please stay tuned and check out our website, simasurgery.com.
Thank you, Faris. You're going to do great, and it's been a pleasure teaching you.
Thanks.